I'll just explain briefly to the applicants. So what we call a noon conference is probably what you call a morning report. If you still do that at your institution, it's the live patient case, going through clinical reasoning, et cetera. So you'll feel that. What we used to have that during the morning, and that's really hard to schedule on busy clinical services, and it was hard for people to attend. So we moved morning report to the noon hour with food. What used to live in the noon hour is now what lives in those educational half days on those Wednesday educational sessions. So just to give you a sense of what this is going to be.
Awesome. Thanks, Jeff. Well, I guess with that, it looks like we have a pretty good group hopped on, and people will be hopping on later. So we will go ahead and get started. As I mentioned, I'd like to introduce our applicants, or excuse me, our discussants for today. So I'm going to let them kind of introduce themselves. So maybe we can start with Ryan, our PGY1.
Yes. Hi, I'm super excited to be here. I'm one of the interns that joined the primary care track. It actually had a lot of the things that I was looking for, so go PC. Super excited to be a discussant here. I'm originally from Texas Tech University. We actually had quite a bit of people come over from that campus to hear this program. I've loved it so far, it's amazing.
Thanks, Ryan. And Cara?
Hey guys, I'm Cara, Saxon. I am super excited to be here today. I'm originally from Washington State and went to UW for med school. I see there's a few applicants from UW, so go dogs. Super excited to have everyone. Again, I'm in the primary care track as well and interested in primary care with a special emphasis in women's health.
Awesome, thanks, Cara. And last but certainly not least, Thomas.
Hey everybody, my name is Thomas Johnson. I'm from a little north of Los Angeles, but did kind of all my schooling in Texas, graduated from University of Texas Medical Branch. This is the first day we don't have an applicant interviewing from there as far as I saw. Usually we have at least one or two, but I'm actually going to be doing geriatrics fellowship here at Colorado next year. Really excited, loved this program. If you guys have any questions, please reach out to me.
Thanks, Thomas. So they're going to be our residents who are kind of discussing the case. They don't know anything much about this case. And then Caitlin is going to be the one helping present the case.
Yeah, hey everyone, my name is Caitlin. I am also a PGY2, and I'm from Minnesota and went to medical case. This was a case that Ben and I had actually worked on together last year at Denver Health.
Yeah. Awesome, thanks, Caitlin. Yeah, and so my name is Ben from outside Chicago, going to primary care. And like Caitlin said, full disclosure, this is an older case. It's a case that I handed off to Caitlin in the morning, and then her and her team kind of took it away. And there's a couple of reasons why I want to talk about this case, which I will talk about. First off, welcome applicants. We are all so excited for you to be here. You've come from all over the place. I always love throwing these maps together because it reminds me that there's places outside of Denver during the pandemic. So we're so excited for you to virtually visit us. And like Jeff was kind of alluding to, so our noon conference typically outside of COVID times is done in person. Since COVID has caused us to change some things, we do a daily virtual conference, which you're experiencing right now. And then when able, we still continue to do some in-person teaching when it's safe. And then we also have a really active YouTube channel. So at the end of this, I will say smash that like button to get us some more likes on YouTube. So a couple reasons why I wanted to talk about this case is this upcoming week was the anniversary that the United Nations General Assembly designated March 23rd World Down Syndrome Day. And then even more recently, so a month ago, Dr. Barry Martin and his colleagues, who I think I saw him on our call, he's one of our family medicine faculties, published these medical care guidelines for adults with Down syndrome. And this indeed is a patient with Down syndrome. So with that, I will turn it over to my co-chief, Danny, to share his screen and take some notes for us. And Caitlin, if you want to go ahead and give our discussants the first bit of information about this patient.
need to be off mute for that. This is a case of a 52-year-old gentleman. He has a past medical history of trisomy 21 and some chronic right knee pain. And his chief complaint in his PCP's office was fatigue, reported by his primary caregiver, which was his sister. And his sister gave us a little bit more information, or to the PCP, that kind of over the previous 3 to 4 weeks, she had noted that her brother was getting extremely fatigued to the point that he really couldn't get out of bed, didn't really want to get out of bed, and just couldn't really seem to have a lot of energy.
Awesome, Caitlin. I'm going to stop you there. So for our discussants, really common complaint with a gigantic differential. When you're looking at this patient and thinking about his age and then his history of Down syndrome, is there anything that you start thinking about in terms of when you hear a patient coming into your clinic with fatigue?
So one of the things that I like to ask about fatigue is just about sleep, because I feel like that's a huge part of like everyone's life. But just kind of getting a baseline of like what typically they do.
Karen, Thomas, anything to add?
I think fatigue is like such a broad diagnosis. There's like lots of directions we can go. I will say I really like Ryan's thought about evaluating sleep, especially in patients with Down syndrome. OSA is really prevalent and oftentimes not diagnosed. Another factor with Down syndrome is hypothyroidism is very prevalent. In fact, like regular screening with TSH is encouraged for these patients. So definitely evaluate for other factors of hypothyroidism. Another thought I had was something that we may not think about, like we can think about like blood issues, so like anemia, things like that. Another issue that, I mean, I'm biased. My wife is one of the psychiatry residents, and she's actually working on a project on evaluating for trauma in patients with developmental disabilities, in adults with developmental disabilities. And so fatigue can be, a presenting symptom, especially in patients that have a harder time expressing themselves with developmental disabilities. It's certainly something we should think about.
Awesome. Yeah, I think you're both getting at probably fatigue is just such a big box. Thomas, I like how you're narrowing it down based on this patient's characteristics. But it sounds like this is one where you really need a little bit more history. So Caitlin, why don't you give a little bit more history on what his sister is reporting?
Yeah, so he has been sleeping just fine. In fact, he just wants to sleep all night and all day. Sort of difficult to assess his mood, but it seems like his mood has been pretty stable. He's still kind of his happy self. Doesn't sound like there were any big stressors going on in the home. Really just sleeping all day, can't really move around. And then his sister also notes that he does have this chronic right knee pain that he's been dealing with for the last couple of years. But the knee, and it seems like he has this kind of like new right hip pain as well, that has also kind of come on over this time period, over the past 3 to 4 weeks, just kind of worsening joint pain.
Yeah, awesome. Great, Caitlin, thank you. And then I will add in to that too, also noted have some, I think they mentioned some bruising around, especially that right leg and knee. All right, for our discussants, any other, and does this kind of help narrow your differential, not help, or what other questions do you want to ask Caitlin?
I think I would be wondering about this bruising more, and was there any recent trauma to the area, or like has he had any falls? And then trying to suss out like it may be hard to suss out the hip pain a little bit more, but like, is he still able to walk, and what's his function like? Is it like debilitating, or is he just saying it's bugging him?
Yeah, good questions. It's not debilitating. He's still able to walk around, but it definitely is causing him some pain. In regards to the bruising, he does have bruising on both of his legs, but more prominent on the right leg. And she does note that there's like one specific area of his leg where the bruising seems to be a little bit more extensive, which we can talk about more in the physical exam. But the bruising has also developed over the previous 3 to 4 weeks.
Great. Great, Kaylin, and great questions, Cara. So I think this bruising, it sounds like, Kaylin, I don't remember if you mentioned any trauma related to this.
Oh yeah, sorry. Yeah, no trauma, no falls or anything like that at home that would have caused this.
So for our discussants, when you're hearing atraumatic, easy bruising, is there anything that pops to your head, or how do you think through that chief complaint?
I kind of think about easy bruising. I kind of separate it first into two big categories. Is it a blood problem, or is it a soft tissue problem, like skin and vessels? So I'm thinking like, senile purpura, vasculitis, you can see petechiae and purpura there. Whereas a blood problem, I'm thinking more like thrombocytopenia, and we can get into like our differential for blood clot causes later.
Awesome, Cara. Yeah, I love that. I love breaking things into big buckets that we can kind of start thinking through. And then I'm just kind of following the chat. So looking for CBC, Evan's asking a great question in terms of diet. Caitlin, do you want to go a little bit into, we can dive into his diet and maybe get a little bit more history in terms of his past medical history and the meds that he's taking?
Yeah, it's a good question about the diet. He has had some dental pain over the past couple of months, to the point where he's already a really picky eater, but because of this like increasing dental pain, he's really just been eating like buttered noodles and rice at home. So that's mostly been his diet recently. And then moving on to past medical history. So really just hypertension. And then he has this chronic right knee pain from I believe it was a knee, like a tibial plateau fracture back in 2017. And then a B12 deficiency. That was really it for past medical history. Do you want me to go ahead, Ben?
Yeah, that sounds great. Let's fill out the rest of the social family med history and things like that.
For social history, so he lives at home with his sister, who's his primary caregiver, and also his dad. And he has no alcohol, smoking, or other recreational drug use. Remember, I don't have his allergies, nothing crazy. And then medications, he takes Voltaren gel, or uses Voltaren gel. He uses Advil every now and then. He has amlodipine. And then he gets weekly B12 injections. And then for his surgical history, he had some sort of heart surgery as a child. The family doesn't remember exactly what it was, and we don't have any records of it.
Awesome. Thanks so much, Caitlin. So just kind of rounding up our history and some review systems. So I'm just going through the chat really fast. So any weight loss or other B-type symptoms, Caitlin?
No fevers or chills or night sweats. he's had a little bit of weight loss over the past month or so with this like dental pain that he's been having. I want to say it was maybe like 10 pounds or so, nothing crazy.
And then just a couple of questions out of the chat. Any other vitamins or supplements? Nothing that I remember from talking to him.
Nope, just the B12.
Okay, and then asking how much Advil or diclofenac does he use?
I don't remember if we asked that or not. I think the diclofenac was just kind of daily as needed. And I think the same was for the Advil as well.
Thank you.
And for our discussants, what other questions are popping up into your head that you want to make sure to ask?
Yeah, so I love where all the different directions some of these chat questions are going. So I totally agree with Cara. Is this a blood problem? Is this a soft tissue problem? Is this a potential malignancy issue? And there's so many causes of all these different things. I was really interested in the past medical history, see if there's like childhood malignancies, which it doesn't sound like, but in congenital heart disease though does make it concerning. Could there be, schistocytes from a shear with like some sort of valve replacement, anything like that? It doesn't sound like we have a great history with that. I think something that could help us in this patient, it sounds like you handed the patient off in the morning, so I'm assuming inpatient. What made the sister bring the patient into the ED at this point?
Yeah, good question. So at his PCP's office, they did regular blood pressure check, and he was found to be hypotensive, I think 70s over 40s. And so that, in light of everything else going on, they sent him over to the emergency department.
Awesome. And I guess with that, we can dive into that physical exam, kind of as he changed, kind of what progressed when he got to the ED.
Sure. So en route to the ED, he got a very small bolus of fluids, and his blood pressure was 102 over 50. His temperature was 98.1. His heart rate was 76. And he was statting 100% on room air. And then on his physical exam, just generally, he is in no acute distress. He is relaxing comfortably. He has a doll with him. For his kind of HENT exam, it looks like he's got some moist mucous membranes. His gums though are bleeding, and it looks like he had several missing teeth. For his cardiac exam, regular rate and rhythm. We did appreciate a holosystolic murmur, kind of heard throughout the cardiac exam. And then his lungs were clear to auscultation bilaterally, no crackles or wheezes. And then his belly was soft, non-tender, no masses were appreciated. And then for his neuro exam, he was ANO times 3 to 4, no focal deficits appreciated. And then for his skin exam, which we had talked a little bit about already, he did have diffuse ecchymoses throughout both legs, but he had a one larger area kind of on the right inner thigh that measured maybe like 20 centimeters.
All right. And I hope I share, can you all see this? And for our discussants, kind of what would you call this, bruising pattern, or what are your thoughts when you see this? And it may be a bad question. When I'm thinking about bruising, I'm thinking about, is this more purpura-like, hematoma-like? Is it more petechial? And what would this look like to you?
I mean, it's pretty blurry for me here at the VA, but it's looking perhaps more like a purpura. I can't really tell if there's petechiae or anything like that, so sorry.
It
No,
also
that's totally fine.
is like I'm almost seeing like some green on like the right anterior shin that looks like it could be kind of old. So I'm seeing like diffuse purpuric lesions in different stages of healing.
Yeah. Awesome. Yeah, so getting some help in the chat as well. So distribution not typical for trauma-related bruising, so maybe more blood-related, and then potentially thinking about abuse. And I think Dr. Martin had mentioned earlier in the chat, always be thinking about abuse in patients with Down syndrome or any cognitive disability. So let's go ahead. I'm going to stop sharing that, and let's get some blood work. Besides we'll start with just the CBC and CMP, the emergency department lab, and then we'll go from there.
All right, sounds good. Let's see, for his CBC, his white blood cell count was 2.9. His hemoglobin was 7.4, and his platelets were 137. And then for his BMP, he has a sodium of 134, potassium of 3.1, chloride of 100, bicarb of 21, a BUN of 24, and a creatinine of 2.0. And his glucose was 108.
Awesome. Thanks, Caitlin. And then in terms of any other labs right off the bat that our discussants want, or people in the chat, any other labs that you want us to throw on as you're getting ready to admit this patient?
Sorry, before we do other labs, Caitlin, what's his baseline creatinine?
Good question. It looks like his last one was 2.04.
Okay, thank you.
But he has some sort of underlying kidney disease that I forgot to mention.
That's great.
Yeah, Jeff, what are you thinking about in terms of someone coming in with these labs and when you're looking at their creatinine?
Yeah, I think there's so many things we ask as a matter of course and get as a matter of course, like CBCs and sevens and med history that are so much more important when someone has a diffuse complaint like fatigue. You know, what med did they start when this complaint happened? What did the labs look like before and after? That we need to think about them more specifically as opposed to just more information that we might gather.
All right, so in the chat, we're seeing a lot of people want to see a smear and some coags. So did we get any of those, Caitlin?
Yes, we did. His smear, he just had 1+ anisocytosis and then decreased platelets. He has an INR of 1.31, a PT of 16, and a fibrinogen of 251. And a haptoglobin that was 71, which is normal.
All right. All right. Well, we're getting a few other requests in the chat, but I'd like to turn over to the discussants really quick and see kind of how would you put this patient in a one-liner when you're getting a call from emergency department. If you're going to do a problem representation for this patient who's started out in the clinic, now in the ED, and you're going to have to, and you're admitting them to your service.
I'm happy to take a stab at it if you guys want. I would say this is is he 52 or 58? Sorry.
52.
Number one thing. Okay. 52-year-old gentleman with trisomy 21 who's coming in with about a month of fatigue, arthralgias, and easy bruising. found to be hypotensive with diffuse purpura and a new diagnosis of pancytopenia.
Yeah. Thanks. Thanks, Danny.
Yeah, so
pancytopenia.
like to the past medical history, congenital heart disease and CKD.
Awesome. Great job, Cara. That was fantastic. And I think when I'm reading this problem representation, I start having a differential diagnosis that starts coming in my head of things that I want to make sure I'm ruling out pretty quickly. How about for our discussions, kind of what would you be putting towards the top of your differential, and what are some other things you'd be thinking about?
I feel like with the labs and everything, I'm thinking more of like hematologic processes or like malignancy, just because I feel like with the pancytopenia, there needs to be something bigger, like a bigger picture going on. And especially since this has been going on for a while. So like thinking about like acute versus like a chronic process.
Yeah,
Awesome. I love that. I love that, Ryan.
I would also think about like MAHAs. If like, it's hard to assess if this guy's like acutely super ill right now, just like I'm not seeing him. And Dr. Martin brought up like hypotension is super common in Down syndrome. So I don't know if this is a big change for this patient, but like, if they're more acutely ill, I'd definitely be concerned for a MAHA. And I do like some of the chat requesting vitamin C levels. And then also like a B12 deficiency can result in pancytopenia. I actually had a case at Denver Health with actually a hemolytic appearing anemia and pancytopenia that was actually severe B12 deficiency before. So I think we need to explore that as well.
Awesome. Fantastic. Cara, anything to add?
Not at the moment. Yeah, I'm really concerned about malignancy and hematologic processes.
Yeah, awesome. I'm just trying to keep up with the chat a little bit. So I think in terms of these are all decreased from his prior CBC, which was about a couple of years ago. So this is all new for him. Great. And then in terms of when we see, so the word that jumps out to me is that pancytopenia word in that problem representation. Do you, does anyone, and this be in the chat or our discussions, do you have a way that you think about pancytopenia versus another, like an isolated anemia, isolated thrombocytopenia? And I think like oh, go ahead, Cara.
Oh, are you just trying to get it? Like, I think you have to have 2 cell lines down for it to be pancytopenic.
Yeah, great. I think that's yeah, important to actually define kind of what we're talking about with pancytopenia. So yeah, so anything that causes pancytopenia. So when we think about our cell lines, we have 3 cell lines. Anything that can cause all of them to be diminished, you need at least, can also cause 2 of the 3. And then I like to think about it in terms of like the most basic way, in that, is this a production issue? Is the bone marrow getting filled with something that's not supposed to be there? Is it a destruction issue? Are we destroying our blood cells? Or is this just that the bone marrow is empty and that this is a total production issue? Which I think I said twice. So, and we can think about a different differential for each of those. So I don't know if our discussants or people in the chat want to add in kind of what our thoughts are in terms of trying to narrow down what can be the cause of pancytopenia.
So for infiltration, I think about either malignancy, like infection or fibrosis. I guess like you could say fibrosis, is the bone marrow empty as well? And then for like the production issue, that could be like medications, toxins, infections, metabolic issues, so like vitamin deficiencies we talked about, are my initial thoughts.
Yeah, that's fantastic. Thanks, Thomas. Great. So we're getting ready. This patient's come up to the floor, and we are going to order a few more labs. So kind of after being able to browse through the chats, discussing kind of what labs do you want to prioritize, and what other, any imaging that you want to obtain, or yeah, what are your thoughts and next steps?
Did we get things like LFTs and like reticulocyte count?
His LFTs were normal. And his reticulocyte index, I have not calculated. I think, Ben, it'd be safe to say low. It was low if we calculated it out.
Yes. Yeah, it was, I don't have it in front of me, but it was hypoproliferative.
And did we get like iron, B12, folate? Someone mentioned vitamin C.
Yeah, so we got vitamin C levels. That one takes about 10 days to come back, 7 to 10 days. So we don't have that result right now. His B12 level, though, did result quickly. It was 633, normal. And then his serum iron was 69. His ferritin was 120. His IVC was 191. And his iron saturation was 36%.
And then also you want to get like an RBC folate. And I probably would want to.
Awesome, Thomas. And can you comment on the RBC folate?
Yeah, just RBC folate tells us more about like the true storage of folate. Like normal folate levels can fluctuate a lot and are like replenished really quickly. RBC folate gives us a better idea of chronic folate deficiency.
Yeah, I don't have the RBC folate in front of me. We did check a serum folate, and that was normal.
Awesome. And I see Evan commenting on some infectious disease labs as well. I think that's probably one that I forget all the time in terms of pancytopenia is in different infections. So Evan was saying HIV, HCV, EBV, and CMV. I don't remember if those were checked, Caitlin.
Yeah, those were all checked. His HIV was negative. His EBV and CMV were both negative. And then his HCV antibody comes back positive.
Awesome. And August is asking, how are his hair follicles and any bruising? August, what are your thoughts there in terms of asking about hair follicles?
I had a pretty similar case to this one. I'm worried about vitamin C deficiency in this guy that's eating buttered noodles and only buttered noodles. I wonder if he has scurvy.
Yeah.
And maybe along the lines of what August is getting at, which I think I heard in the physical exam that he's missing teeth. And I'm always, as you can tell, a temporal person. But Caitlin, are those teeth lost long since now, or are they recently lost?
I believe they were recently lost. But yeah, his gums were bleeding. I kind of hesitate when I first gave this exam finding, but his gums were a little bit hypertrophic, so like he had some gingival hypertrophy.
Okay, so his mouth looked like a place where acute changes were happening. It sounds like, to some degree. Thank you.
Awesome.
Good
The
one.
other, yeah, go ahead, Cara.
Just for imaging, like just with the hip pain and the knee, I'd probably just get plain films on him just to kind of look for any sort of infiltrative process in the bone. And maybe even consider a CT, like if we're concerned about some sort of like bone malignancy, I would definitely not want to miss that.
And then
Yeah.
I think Natalie was mentioning if there's a protein gap. I can't remember if you said that, but he's got like CKD, anemia, so concerning for like in bone pain, myeloma. And then we would, if that was the case, we could consider getting like a skeletal survey.
Awesome. Awesome. This is all fantastic. Great. And then a couple people are asking, any splenomegaly, perhaps a primary myelofibrosis type picture? Caitlin, I don't remember if this patient had any hepatosplenomegaly.
Yeah, I don't remember that either.
Great. So in terms of kind of as we're working towards narrowing our differential and getting closer to kind of what's going on with this patient, discussants, where would you kind of prioritize? So we have a purple smear. I've seen some people ask for bone marrow biopsy, which will be coming up next. But where are you kind of putting your money down in terms of what could be going on with this patient? Has this changed your differential at all, kind of getting these labs?
For me, it doesn't necessarily change a whole lot. Maybe moving like the vitamin C and like other deficiencies up like slightly higher. But I think until we get like a bone biopsy or at least like some platelet studies, I think hematologic and the malignancy are kind of like, for us, things that we don't want to miss.
Awesome, right? Yeah, I think that's a great way to approach these patients. But what things do we want to rule out now, and what things can't we miss? So awesome. Well, let's go ahead. He did get a bone marrow biopsy pretty early on in his course. Do you mind, Caitlin, going through the results of that?
Yes. So he gets a bone marrow biopsy. I think it was on like day 3 or 4 of his hospitalization. And it was consistent with myelodysplastic syndrome with single lineage dysplasia. Do you want me to go through everything? That's basically it. No fibrosis, negative CD5, negative CD10.
Yeah, awesome, Caitlin. No, I think that's good. Great. And I saw that Dr. Martin had mentioned that the risk of hematological malignancies in patients with Down syndrome is increased up to about the age of 30 and then levels off in identical risk to the general population. Discussants kind of, I asked this in that leading way, but does this kind of explain all of his clinical presentation, or what are your thoughts, or what do you still want to stack before we kind of close this case?
I think I would still like to know like some of his nutrition status, just because I feel like that's more of like a outpatient thing that we can like manage, but would also set him up for failure if we were just like, oh, this is just cancer, and that was completely the only thing that we looked at and pinned on. Especially because like nutrition's so easy to kind of change with like a consult and be like, hey, know what he's eating, and then maybe just getting like more on top of that.
Yeah, I think that's fantastic. Thomas, anything else?
I just want more info on the single lineage dysplasia. Like that's like, that basically doesn't explain, like they're not really explaining what that is. So
Yeah, and I'm not a hematologist. From my understanding, when they grade myelodysplastic syndrome, it's graded by how many of the cell lines show evidence of dysplasia. So for their bone marrow biopsy, and I think the pathologist commented that this was megakaryocyte dysplasia. But right, even with just a single line, you can still have decreases in all of your cell lines because it can crowd out the other bone marrow. But yeah, I see it in the comments asking, don't quite understand this heavy bruising pattern with platelets of 137 and that INR is 1.3. So I think with the next aliquot of information, we'll get our diagnosis. But going back to when we look at pancytopenia, and then when you think about easy bruising, are there any things that line up here that could explain both of these outside of the MDS?
Like the function of platelets, are they aggregating properly? Are they activating the cascade properly?
Great. Yeah, I love that. I love that that thought process. So is this just a true platelet function issue?
I guess with that in mind, I don't know if this is going down a rabbit hole, but think about sending like a von Willebrand panel, like antigen and activity. I don't think of von Willebrand as causing like other cell lines to be disrupted, but it obviously can affect your platelet function, and you could have technically kind of borderline normal platelet counts. Like his was like 137, I think.
Yeah, fantastic. Great. And I think there's one thing on here that I'm looking at too that could tie that we've kind of talked about, and I think some people have mentioned, but this nutritional deficiency. So vitamin C causing that easy bruising, and then just generalized malnutrition also causing pancytopenia. So Caitlin, do you want to go through the rest of the labs that we got?
Yeah, absolutely. And I'm seeing someone in the chat asking about about the hepatitis C antibody coming back positive. So his hep C RNA PCR did come back very elevated at like 300,000. And then I think the only other thing we haven't talked about on his day of discharge, we got the vitamin C level back and it was undetectable.
How did this guy get hepatitis C?
Yeah, it's a good question and something we were racking our minds about. Our only thought, because he didn't do any drugs, he was not sexually active. Our only thought was that he had cardiac surgery as a child, and he's 52 years old. So it may have been like a transfusion-related hep C infection.
Yeah, great question, Thomas. And I think this is almost certainly a transfusion-related reaction from when he was a child. And then I see Mark asking, just to round this out, he did get a parvovirus 19. That's another one that I've seen cause pancytopenia as well. So just another infectious disease. I mean, he did get a parvovirus 19 that was also negative. So great. Well, awesome job discussing. So I think the big things that I took away, from my learning in this case was causes when patients say they're having easy bruising, ways to kind of break that down into some big buckets, and then ways to work up pancytopenia. And fortunately for this patient, so he received nutritional supplementation, and all of his counts have recovered completely since then. And so his MDS, honestly, talking to hematology, he follows with our heme clinic, one of our prior chief residents actually, and talking to him, it seems like it may have been an incidental finding, this megakaryocyte dysplasia, because all his cell counts have recovered so nicely. Great. Well, with that, I do want to share just a couple knowledge pearls. This was his oral cavity. Sorry, I couldn't get this up, but you can see having some of the gingival hyperplasia. And then I think someone early on asked about his skin as well. So some of the findings in scurvy, you can get kind of these corkscrew hairs. This isn't a great example of corkscrew hairs, but they definitely show kinking. And we'll talk about those things. So I really want to talk about Down syndrome and scurvy. Not that they're always related, but that those are two things to think about. So I'm going to talk in terms of objectives. So we update you on the 2020 guidelines for preventive health for adults with Down syndrome, and then a quick scurvy review and looking for signs and symptoms. So Down syndrome, probably most people know that this is the most common chromosomal abnormality in humans. What I didn't know, it's actually really common. So 1 in 730 births, and it's actually increasing. And then I think even probably more when you look at the life expectancy of these patients. So back in 1960, life expectancy of a patient born with Down syndrome was 10 years. And in 2007, this is up to 47. And it's actually even higher. And patients born with Down syndrome now can be expected to live to 60 to 65 years. The vast majority of this is due to advancements in cardiac surgery and advancements in cancer treatment in childhood. So you may be asking, as a clinician, kind of what can guide me when I see a patient like this in my clinic? And Dr. Martin I saw was on here, so I will give him free reign if he wants to talk. But otherwise, this was published in JAMA, and I think Thomas had also hit on a few of these, but increased risk of dementia. So they actually recommend beginning cognitive screening for cognitive changes at the age of 40. Significantly increased risk of thyroid, both hyper and I think hypothyroid as well. So recommend a TSH every 1 to 2 years. And then in terms of atlantoaxial instability, there was some thought that obtaining screening radiographs would help, but they actually recommend not obtaining them, but do screen for signs and symptoms of peripheral myopathy. In terms of diabetes, increased risk as well. So for asymptomatic adults, they recommend an A1C every 3 years, starting at the age of 30, and then any adult with obesity starting at the age of 21. And then increased risk of autoimmune disease, which I think Dr. Martin mentioned during our case, but they recommend specifically screening for celiac disease with just assessment for GI and non-GI symptoms. So maybe asking me, what about this patient with Down syndrome and had this questionable MDS disorder? So lifetime risk of leukemia is certainly higher, so 1 to 1.5%. The vast majority of these are in children, and even more common than leukemia. So polycythemia is extremely common, especially in children. And then this transient myeloproliferative disorder is a leukemia that's almost seen exclusively in patients with trisomy 21. But what about adults? So Dr. Martin had commented, so there's actually really limited data looking at hematological disorders in adults with Down syndrome. So small that one of the studies that I found in 2009, they followed 9 patients. So, and 2 of them had MDS and neither had progression of their disease. But there's really a kind of a lack of data kind of in terms of their risk. I know Dr. Martin had mentioned that this risk seems to level off though. And so they don't recommend any screening for MDS or other hematological malignancies in adulthood. Great. And last, with just a couple minutes, just really quick, run through scurvy. So scurvy, I think, is a super cool disease in the sense that it's easily treatable, and we've known about it for a long time. So it used to be called Purpura nautica. This is a book on diseases of the skin, which was published in 1840s. And from everyone's biochem days, you probably remember deficiency in vitamin C. Dietary sources are citrus fruits, green vegetables, including the worst one, tomatoes, and potatoes. And you may remember that this is the point when I show this, everyone turns and starts looking like this, like they have scurvy. But ascorbic acid is really important for hydroxylation of collagen. So in normal collagen, you have this procollagen subunit that forms this triple helix. When you don't have ascorbic acid, it forms kind of this just kind of mush. And that's how you see all the downstream effects of scurvy. So impaired collagen synthesis, you see skin changes, like we talked about. You see neuro changes because collagen is involved in the myelin sheath formation. You see cardiac changes. So we actually had a case last year of a patient with scurvy who presented with just heart failure. And then the vascular changes like we talked about. So weakened vascular walls, easy bruising, things like that. What about scurvy and anemia causing this patient's pancytopenia? So his was probably multifactorial in the sense that he was grossly malnourished. But there are some case reports and some thoughts that vitamin C plays a pretty integral role in iron metabolism, B12 metabolism, and folate metabolism, which can all cause pancytopenia. But it is rare just to see isolated scurvy deficiency with anemia. Best part about scurvy, super easy to treat. So you do a gram daily supplementation for a month. Important to know that the constitutional symptoms, so the weakness, fatigue, generalized breathing, crummy, improves really fast, but it can take up to 3 to 4 weeks for the gingival and other vascular symptoms to improve. And then a clinical protocol that I learned, don't recheck serum vitamin C levels, that your serum levels actually increase pretty quickly, but tissue levels can take quite a bit longer to improve. So, awesome. Well, with that, any questions? I'll go try to hop through the chat really fast.
One thing, Ben, that I don't know if you knew this, but I'm interested in caring with adults with Down syndrome, and that was like partially what I'm going to be doing in my fellowship next year. And I've worked with Dr. Martin before. One thing that's really interesting that he's talked to me about is the really low prevalence of solid organ cancers in patients with Down syndrome. So why that's important is for Pap smears, it's a large ordeal to get a Pap smear done on a patient with Down syndrome. And like he even said anecdotally, he's never had anyone with any issues on Pap smears when he was doing them regularly. So there's question of, do we even pursue screening for that? And then the screening for dementia is actually more so at age 40 to get a baseline rather than trying to diagnose dementia. It's more to be able to track it better as they age.
That's awesome, Thomas. Yeah, thank you for adding those clinical pearls. And Dr. Martin, looks like your mic's not working, but thank you so much for participating and helping out with getting this case ready. And thank you for your continued work for this patient population. Awesome. And this is a picture that I took in Denver.
Oh, nice.
Denver has the best sunsets.
You do have the best sunsets. You had good sunrise pictures too. I'll throw a quick thank you out to our discussants for not shutting down when we saw MDS appear in name, because it was clearly not the cause, but it's so easy to think, oftentimes we'll do these cases of bicytopenias and pancytopenias, and we'll usually say bone marrow stuff, right? Like what could cause this? Like bone marrow stuff. And then we found a bone marrow stuff, and that was, definitely not the answer, especially a single lineage deficiency. So I want to just congratulate you guys for not closing on that and waiting for the other test to come back.
Can I just give a shout out to Ben too, because he admitted that patient on swing and signed, or overnight, and the next morning he signed the patient out to us and was like, I think this guy has scurvy, because he had noticed the teeth and the gums and the corkscrew hairs. So Ben basically did all the hard work. It was awesome.
Thanks, Caitlin. I did not do the hard work though. You all did a great job taking care of the patient. So. Awesome. Well, thanks, everyone.
That's great. Thanks to the discussants. Thank you, Ben, for leading that great case. And I do love that the labs have to catch up to you by 10 days. That is great. For our applicants, please hang out here for a couple more minutes. We're going to do a little bit of a wrap up to the day.